Next speaker is Adina Wojciechowsku, who is a very valued member of the Brigham faculty. Adina had a circuitous path to her current position, was for years, several years, a faculty member in Dusseldorf, where she contributed significantly to the literature on ultrasound. Transitioned to training at the Brigham and has been for several years now a faculty member in interventional nephrology, where she works hand in glove with Dr. Henschel, who will be the next speaker. She's our major ultrasound resource, both in the renal division and also the Department of Medicine.
I am live. Oh, thank you. Thank you, David, for the kind words and the introduction. Hello, everybody. Thank you for being here until the end. I hope you will have continued fun with my presentation or the last two presentations. It's maybe a little bit less mentally challenging, but maybe visually, since we're going to look at pictures. I am passionate about ultrasound, and oops, this goes too fast. It has been the center of my clinical attention. Ultrasound, including Doppler, for any vascular bed or for any part of the body, including vascular beds and the kidneys, and it has always been my research focus. So transitioning from Germany in 2010 to the United States was an interesting experience, understanding that ultrasound is not being done by the clinicians themselves. And I am very excited to see that there has been a movement forward, that more and more physicians perform their own ultrasounds. And it is my hope to have you all get an interest in at least looking at images, if not to learn point-of-care ultrasound. I have no disclosures, and I would like to highlight the use and interpretation of renal ultrasound, particularly by looking at images themselves, review a little bit the differences and the strengths and weaknesses of other imaging studies that are available for the kidneys. And then I will have a short portion of other applications that are of interest in nephrology and point-of-care ultrasound. So ultrasound, while we have learned to use our senses, humanity has learned to use the senses to detect and make diagnosis. We have had, obviously, a significant progress where we can use technology once to hear into the patient, and obviously with ultrasound to look into the patient at the bedside. So ultrasound is an extension of our physical exam. And I would like to dive directly into a case of a 24-year-old female who had sudden onset swelling and discomfort in her legs. She was slightly hypertensive at presentation, and she had gained weight, 15 pounds, had some edema. Her labs were notable for hyponatremia, slight hyperkalemia, and elevated creatinine BUN, so decreased kidney function, acute kidney injury, significant for the presence of red blood cells, white blood cells, and protein or urine analysis. And this will turn into a question. So take a good look at the images that we see here. We have the right kidney here and the left kidney on this side. And the questions that will come to you will be in regard to these images. So do we have normal-sized kidneys and no right-sided hydronephrosis, normal-sided kidneys with right-sided hydronephrosis, normal kidney with cysts on the right? And do we have small kidneys without hydronephrosis and small kidneys with right-sided hydronephrosis? So there's two questions, one about size and two about is there the hydronephrosis or cysts visible in the kidneys. And here are the images. And I would like you to start voting. I'll give you a few seconds. My screen is very small with the answer, so I'll try to. All right. For now, it's answer C. Oops, where's the answer? Here it is, the answer. Normal-sized kidneys with cyst on the right, maybe with right hydronephrosis. Excellent. So let's take a look at we will get to the answer. So what is ultrasound? Ultrasound is a mechanical wave that is created in these ultrasound probes. There's piezoelectric crystals that produce this wave, and it will travel to the body and will hit different structures and organs within the body. Depending on the fact that there is fluid or there is bone or there's so their impedance, the waves are either absorbed, they are reflected, or they are scattered, or they are refracted. So we will have different intensity and amount of ultrasound waves returning to the probe, and this will then be turned into a black and white image that we will interpret on the screen. When we talk about ultrasound, we have to have the right expressions to describe structures, and everything that is black, where the ultrasound waves have been completely absorbed, means that that is fluid, and typically those would be cysts, hydronephrosis, or the bladder. Anything that is hyperechoic is hyperreflective, so this is frequently either bone or stones, or can be very dense tissues. And anything in between are described as hypoechoic or isoechoic, so different shades of grays that are utilized to describe different organs or structures. So liver and kidney are more hypoechoic compared to the background, and isoechoic is something that is of the same echogenicity. In addition to the black and white intensity of the returning ultrasound waves, we are working with artifacts, and there's two of them mentioned here. One is the so-called dorsal enhancement. That is an increased signal behind any structure that is fluid-filled. Those are cysts and bladder, so we utilize it as an addition to interpret an image. The other thing, though the kind of the opposite would be shadowing, where a hyperreflective structure will cause a shadow. That's more intuitive. So that would be a stone bone nephrolithiasis. Another review is the review of the kidney itself. To remember, you've heard lots about the kidney. You may have seen this may have been part of some presentations during this week, but remember there's the cortex, and there are the pyramids that are triangular shaped, more medial, and then we have the calyces and the pelvis on the medial side of the kidney, where there's the ureter and the vasculature. So when we look at kidneys, and there's two planes to look at, in a longitudinal plane and a transversal plane. By definition, everything that is on the left side, on your left side, there will be cranial versus caudal. So this is headwards and feetwards. The kidney is on the right behind the liver, so it's easy to ultrasound through it and identify. And this is anterior and this is posterior. If it is a transfer cut, the right side of the patient will be on the left side of the screen. The kidney sits behind and underneath the liver. If we look from the side in the longitudinal way, the pelvis is a little bit more hyperechoic. And then note there's these darker areas here that are very symmetric. They are repeatedly there. So we have this hypoechoic and not completely anechoic areas that may be confounded with cysts or hydronephrosis, but in fact are the pyramids. The second part of the question was about the size of the kidney. So the kidneys are normally between 10 and 12 centimeters. There needs to be a certain adjustment to the size of the patient. But 10 to 12 is easy to remember. And it is also, other than the absolute size, it is important to note if there is a side-to-side difference, and anything of more than 1 centimeter would be abnormal. And it can indicate a vascular, post-pyelonephritic, or post-obstructive situation. It doesn't tell you anything about the function, but needs to be noted and separately described. Large kidneys have their own meaning, and whenever a patient has a kidneys above 12 centimeters, and one of the most frequent diagnosis is diabetes. This is due to hyperfiltration, just as well as in preeclampsia. Very acute GNs and AIN with infiltration of many cells or a renal vein thrombosis increases the size of the kidney. And infiltrative diseases like amyloidosis, multiple myeloma also increases the size of the kidney. So not just small kidney size is important to note, but also large kidneys. The echogenicity of the cortex is by comparing the echogenicity of the kidney with that of the liver or the spleen. And it should be a little bit darker than liver or spleen. And this is an example of an hyperechoic kidney with the pyramids being particularly well visible. And note here, and I want to point this out because there's frequently the mistake of thinking, oh, the kidneys are hyperechoic. That is a chronic kidney disease situation. Do not take that as a sign of chronicity. Take it as a sign of medical disease, and the chronicity will actually depend on the size of the kidney. This is definitely an acute event with a medical disease. The opposite of having increased echogenicity of the cortex is having increased echogenicity in the pyramids area, which is the hallmark of medullary nephrocalcinosis. Do not expect to have shadows reflecting. It's not a stone, but the small deposits of calcium present like this. And here are the pyramids that are now hyperechoic. So coming back to our case, we have a right-sided kidney with the pyramids. So these are not cysts, and this is not hydronephrosis, and the size of the kidney is normal. So the correct answer was, I think, was it C? I believe it was C. So normal kidneys, no cysts, no hydronephrosis. Second case, 57-year-old man with flank pain, worst pain ever, nausea, vomiting, a little bit tachycardic, febrile, in distress, worsened acute kidney injury, red blood cells, white blood cells in the urine. So what is the appropriate imaging for this situation? And vote now. Is it a CT angiogram with contrast, a CT urogram with contrast, a renal ultrasound, and a KUB? A renal ultrasound with color and Doppler, nuclear scan with furosemide. Please vote. I don't see, oh, there it comes. What would be the next step, what would be the most appropriate imaging? No voting, or I don't see it. Okay, so we'll keep going. Oops. So there are ACR, Medical College of Radiology appropriateness criteria that indicate that in a patient with flank pain, the options for imaging would be a CT without and with contrast, or an ultrasound of the kidneys, the bladder, retroperitoneum, and a KUB, or a CT without contrast. So obviously, in a patient with renal failure or chronic, maybe acute or chronic, we would not want to do a contrast CT. So the combination of kidney ultrasound and a KUB would have been the right answer for this question, C. So let's look at these pictures. These are the ultrasound images of this patient. This is the right kidney. This is the left kidney. Take a moment to look at them and kind of try to decide what is different. And then the questions will be, oops. Do we have normal kidneys? And do we have a normal right kidney and a cyst on the left? Do we have normal left kidney, hydronephrosis on the right? Do we have bilateral hydronephrosis? And do we have hydronephrosis on the right and a cyst on the left? So the challenge is there cyst? And here are the pictures. And I admit it's a little bit more difficult to interpret pictures that are still pictures instead of movies. All right, the voting is happening. Very good. Looks to me like hydronephrosis on the right and cyst on the left is going to be the winner. Okay, so let's try to think about hydronephrosis. And hydronephrosis would be seen like this. This is the kidney, and on the medial side, we have this triangular area, which is the pelvis, and the pelvis and the calyces are visible here. Typically, you don't see anything in that area, so no hydronephrosis. You wouldn't see that. This is mild hydronephrosis. And the next stage would be moderate hydronephrosis, where the calyces are dilated. The pelvis may appear like a cystic structure. This is moderate. And then there is severe hydronephrosis, where you have bizarre shapes that are not, where the kidney is not recognizable as such. We call it sometimes bear paw phenomenon. That would be severe. So the classification is usually mild, moderate to severe. And I think a common mistake in nephrology is to rely on these words where the ongoing debate between urology and nephrology will be, well, it is only a mild hydronephrosis, so we don't need to do anything about this because this is not causing renal failure. And I want to point out that there is it's always a good debate, but we can have false negative findings with obstruction, and that is the difference, obstruction and hydronephrosis. While hydronephrosis is an image, and the pressure and the obstruction it causes is a different thing that is not depicted on an ultrasound image or by describing the degree of hydronephrosis. So any patient who may have retroperitoneal fibrosis or tumors, or be actually in a pre-renal state with little urine production or early and sudden obstruction, can have mild hydronephrosis, but still have obstruction and severe and acute kidney injury being caused by this. On the other side, we have false positive results where in pregnancy or with reflux or after relief of obstruction, there's a persistent hydronephrosis, but it doesn't have an obstructive effect. So what is the solution? The solution is to perform a nuclear scan and not just a MAG3 scan to assess differential renal function or perfusion with deep TPA, but to ask for a diuretic renal, where the addition of furosemide will help differentiate if it is an urodynamically significant obstruction. Ultimately, particularly in advanced kidney failure, this test may not be very helpful, and just nephrostomy tubes and relief of the obstruction will a posteriori give you the right diagnosis. Cysts look like this. So we have the kidney, and often they are more in the parenchymal area. They have this dorsal enhancement that I mentioned at the beginning, where which is an artifact but helps you interpret the picture. And the opposite would be a kidney with hyperechoic areas. These are actually stones with their shadow. So they may not be as easy to identify as one pictures that they would be identifiable on ultrasound. It takes a moment to really be able to see that. There's an additional artifact that I want to mention, which is the so-called twinkling. The addition of color will show you that it's truly a stone. This is not color from a vessel, but an artifact that helps you interpret the image as being a stone. A non-contrast CAT scan is the best method to find at least small stones, particularly if they are somewhere in the ureter. Your ultrasound is not great to detect small stones somewhere between the kidney and the bladder. So the most appropriate image would be renal ultrasound with KUB. This is the answer to the question. We would not want to give contrast. The Doppler would give you vascular information, but with the image we have seen, or a vascular problem with this presentation of flank pain could be an option, obviously, but bilateral flank pain is probably rare to be caused by a sudden dissection. And nuclear scan with furosemide would be only later of importance potentially. So the role of B-mode ultrasound is to detect size and aspect of the kidneys, and every AKI patient question or CKD patient that I see, even though they've had CAT scans and and I'm being told that it is not hydronephrosis, I would additionally ask for the ultrasound and specifically to look at the parenchymal thickness, echogenicity, so it helps understand the bigger picture and the gestalt of possible kidney disease. It is a good ways to detect, or the way to detect hydronephrosis, polycystic kidney disease, bladder size and aspect, as well as PVIs and perinephric collections. For stones, it is a little bit difficult, as I mentioned, to find smaller stones between the bladder and the kidney. Cysts and tumors can be seen. Can we say this is a malignancy? That becomes a little bit more difficult. So additional imaging is needed in these cases. And for biopsies, it is a great tool. The main problem may occur when the patient's size may be limiting. So overall, I would recommend at all times that any patient who has kidney disease or hypertension should obtain a renal ultrasound. And I hope that you all agree with me. Can we use it to look at kidney transplants? Of course. Particularly in transplant, the kidney is more superficially located, so a lot better to see in most circumstances. And again, the questions can be size and aspect of the kidney, hydronephrosis, which occurs frequently, perinephric fluid or collections occurs more frequently than in native kidneys. Look at bladder stones and perform the biopsies. In kidney transplants, particularly at the beginning of or right after transplantation, it is important to perform serial exams. Can we use color and Doppler? Yes, we can. Color and Doppler is helpful for the diagnosis of renal artery stenosis. It is an excellent tool. Doing a Doppler requires, though, a longer training, so it is not as easily learned as basic point-of-care ultrasound. It is an excellent tool to look at kidney transplant or effusion. If there's been a biopsy and you have an arteriovenous fistula, it's the method of choice. Transplant renal vein thrombosis, it is very pathognomonic change in spectrum, so great tool. Tumors, the same a little bit, may need additional imaging, and renal vein thrombosis of native kidneys. This is a frequently debated question in patients with a nephrotic syndrome. As you know, it is a very difficult diagnosis on ultrasound, so I would probably not take it as the first choice. unless the thrombus is really huge, you may be able to see it, and the patient is then additional methods like non-contrast MRVs would be probably the method of choice, particularly in someone who has severe kidney dysfunction. So kidney ultrasounds are inexpensive, non-invasive, non-toxic, and easy to repeat. So please utilize or ask for them as often as possible, or do that yourself. We always hear everything is operator dependent in ultrasound, but I may say that everything else is operator and reader dependent. I had a rotation to the radiology department in Germany during my training, and my thing was to take a chest X-ray and go to different radiologists and ask them all how they would interpret it. I can tell you there was a lot of variation just as well. So don't believe that the CAT scan tells you everything. It's still the reader behind it. So you become the reader and the one who performs the ultrasound. That will take away a lot of variation. I would encourage everyone to learn to do point-of-care ultrasound. And while looking at the kidneys would be one of our main interests, obviously, and this mnemonic by Abhilash Korotala, the seconds checklist, may help you remember what to describe and look for. So when you do something, you should do it systematically and with a structure, and not just take a quick look. So seconds checklist reminds you of looking at the size, at the echogenicity, at the collecting system, at outliners, which would be tumors, notable lesions, cysts, tumors, stones. One can add the Doppler, particularly if you're interested to find out about venous congestion and surroundings with perinephric collections. The benefit of learning one can learn kidney ultrasound, but adding other organs to your ultrasound is key or can be extremely helpful. And I can't even yes, there are so many indications for ultrasound for patients in nephrology, other than guidance for procedure and catheter placement, the kidney ultrasound. There's a dialysis vascular access, there's a focused cardiac exam. So multi-organ application is the way to go. And for the volume status, it requires abdominal ultrasound. It sounds daunting, but it goes quite fast. The IVC and long looking for collapsibility, looking for fluid in the cardiac ultrasound, answering only simple questions like EF effusion and the lung B lines and A lines. And this is how we're looking for the IVC. We call it the happy whale sign. We don't have to go too far to say, okay, measure things and diameters. If you see this is definitely a dilated IVC with high venous pressure, so diuretics would be absolutely okay. Measurements can be done to obtain a right atrial pressure, but I would stay away from too many measurements. This is how you see fluid, the so-called positive spine sign. So this is headwards, this is the diaphragm, this is not the lung, this is a mirror image. And fluid can be seen here when it's black. So you see the spine continuing, and this is ascites. The lung ultrasound is done in 8 zones, 1, 2, 3, 4, 5, 6, 7, 8. It is also a relatively simple ultrasound, and it looks only for artifacts. We don't really see the lung. And the differentiation is mostly if we see A lines, which are reverberation echoes, which means it's an aerated lung, versus B lines that look like little sun rays. Could it be, is it only fluid? Not necessarily. It can be interstitial thickening of other causes. The echo helps we have different planes, the parasternal axis, short and long, and the 4-chamber view. And it is relatively easy to see if the function is decreased once you know how to obtain the parasternal long axis. The addition for more trained ultrasonographers is duplex, and it is extremely helpful to differentiate acute right heart failure from from not mostly right heart failure with venous congestion by looking at the hepatic vein Doppler, the portal vein Doppler, and the renal vein Doppler, which is down here. If things change like this, the pulsatility in the portal vein is increased and the renal vein has decreased perfusion. This is the moment where diuretics are definitely essential, and it's not a forward flow question. And similarly, in hyponatremia, since it is all a fluid or volume status plays an essential role, one can monitor the changes in pulsatility in the different beds to assess the effect of decongestion, basically. And similarly for liver disease, a multi-organ ultrasound is, I think for me, this is the most frequent time where I do a multi-organ assessment, because it is, again, very difficult to differentiate between ATN, maybe cardiogenic effects with renal failure versus the true hepatorenal situation. So in summary, every nephrology patient should have kidney ultrasounds, maybe serial ones. Look at the images and not just the interpretation. Learn to do it yourself. Be aware that ultrasound is a great tool, but obviously all the tools are needed. And every imaging technique has strengths and weaknesses, and the multi-organ focus is extremely helpful for volume status assessment as well as AKI in combination with liver disease. And thank you very much for your attention. I'll stay in for questions at the end of the last presentation.
Thank you, Adina.